I go again to hidradenitis suppurativa as probably the next obvious, step. And again, there are some diseases that are BMI dependent. There's some that kind of go along with, those methods of can you improve their disease by improving their weight or by improving their BMI. I think again, sky's the limit in the opportunities with the inflammatory cascade. You see again the benefits of that 17 pathway. Would that be the case in simplex chronicus or prurigo nodules? Would you see that where we have other responsive dermatoses now all of a sudden having those pathways inhibited? I mean, the efficacy and the strength of that inhibition would have to be somewhat, you know, kind of elucidated. But again, a comparison study, sure, side by side with someone who may be on topical steroids versus topical steroids with the GLPs, you could almost think, is this like a concept where you're thinking about and instead of or, right? You're thinking, let's do this and do a GLP versus let's do this or we'll do a GLP. I think that might be a better pathway down the road for dermatologists to gain some comfort because there's still the understanding that their active treatment will still do the work. I mean, adipose tissue, has immune effects just like, again, the impact of insulin growth factor, maybe some other neurotransmitters that are impacting other cascades. It kind of goes in reverse. If you reduce the amount of adipose tissue, would you see a reduction in insulin growth factor of some of those other, transforming growth factors that go along with, basically what fat creates? I mean, in the same way that keratinocytes are dendritic cells, we're seeing again, adipose tissue can be a strong source of inflammatory, mediators. So I think the sky's the limit in what we can discover by, again, changing someone's body mass index, for example, or adding these therapies to, treatments that might not be successful. Maybe rather than switch somebody off a biologic that may not be responding, maybe we add the GLP-1 first rather than do a class switch and see if that, impact on the adipose load, might improve things. So a lot of different ways to look at, the potential for improvements there. Oh, I think dermatologists, we should have no problem writing metformin for a lot of patients who might, again, be a little heavier, who have insulin resistance that's affecting their skin disease. Again, we should have no problem writing GLP-1s. I mean, patients are getting it themselves. So dermatologists would be completely missing the bus if we're not, endorsing these drugs when they're appropriate for the right patient. But I think also, just talking to patients simply about dietary benefits of, exercise, of weight loss, of cutting out alcohol and cigarettes and, watching their diet. I mean, we talk about it with rosacea, we talk about it with other, integrative type processes. I don't think there should be any reason why we shouldn't be taking some of this on ourselves. I mean, getting the help of a dietitian should be also, something to turn to, but not everybody has that access or the time. And I think rather than just, punt the problem off, I think we just need to have that extra couple minutes conversation with the patients while we have them in the audience. Same with their spouses and the parents of kids. When we think about, young kids with eczema, if they're a little bit heavy, putting them in a good weight loss program would definitely help.